Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. Today I welcome Dr. Anna Fenton to the podcast to discuss perimenopausal management. Anna is a gynaecological endocrinologist who completed her medical degree at the University of Auckland, a PhD at the University of Melbourne, and postdoctoral research in San Francisco. She was involved in establishing the New Zealand branch of the Australasian Menopause Society and has served on the board of Osteoporosis New Zealand and as president of the Australasian Menopause Society. She is a previous co-editor-in-chief of Climateric, the journal of the International Menopause Society. She was the founding partner of Auckland Bone Density, the first physician-led private bone density service in New Zealand. Anna is currently the clinical lead for Te Whata Ora Waitaha Bone Density Service and works in private practice as a gynaecological endocrinologist. She is actively involved in postgraduate teaching and public education. Kia ora, Anna, and welcome to the podcast.
Thank you very much for having me.
So today we're optimising perimenopause management. We're going to discuss Angie. Angie is a 45-year-old woman who is on the oral contraceptive pill, the combined pill. She was prescribed this for contraception. She has been tricycling this. Her BMI is 25 and she is a non-smoker with no significant family or personal history. She is experiencing sleep disturbance. She wakes up feeling hot at night and has new onset anxiety. She's never been anxious before. Anna, could this be the perimenopause?
Yeah, absolutely. The symptoms that she's describing are certainly very consistent with that phase of our reproductive lives. And the symptoms can certainly occur despite a woman being on the contraceptive pill. If they're going to crop up on the pill, then classically it may be in the week that the woman takes off the active tablets. But certainly the anxiety, the sleep disturbance, the vasomotor instability, these can all occur early and often before any obvious changes in menstrual periods.
Can you define the perimenopause for us?
Yeah, that's a good question. And I think it's been a vexed one until relatively recently when there was actually an international conference that actually set the parameters for defining the various stages in our reproductive lives. So these so-called straw criteria, which are the stages of reproductive aging workshop, define perimenopause as the time that periods begin to change. So these may be very subtle changes initially where cycles vary by 2 or 3 days, obviously through to the more highly variable erratic cycles as perimenopause continues. And as these period changes begin to occur, perimenopause becomes associated with a greater likelihood of symptoms occurring and far more variable hormone levels. So that's kind of the strict definition of what perimenopause is, but clearly the symptoms that some women experience will precede the period changes by a long way and may in fact morph over the years from being a strictly premenstrual phenomenon into something that's a little bit more erratic as they get closer to menopause.
So you've mentioned women may present with a myriad of symptoms and hot flushes may not always be there and the menstrual cycle may still be regular. There are more subtle symptoms that women present with. So can you talk us through some of these?
Yeah, that's a really good question because I think, we've moved to understand that estrogen interacts with every part of the body. So potentially some of the symptoms we see, women experiencing are ones that you wouldn't classically link to menopause. And I think when they occur in isolation, it can be quite tricky initially to make that link. So I would include in that bundle of changes the mood changes, brain fog, which is often forgetting names and words and having sort of short-term memory blanks, the widespread and very common muscle, joint and ligamentous aches, the fatigue, palpitations, and then the almost ubiquitous changes in body shape and changes in weight. So it's not uncommon for the women that we see to have often been off to see one of our colleagues, typically a cardiologist if they've had palpitations, or a rheumatologist thinking they may have fibromyalgia. So it does require sometimes a little bit of thinking outside the box to actually link these changes through to menopause.
It's interesting you comment about fibromyalgia because that's something I've noticed in my practice. You often would have thought, gosh, is this fibromyalgia? But digging deeper, actually, no, it's perimenopause. So that's a really interesting comment that you make there.
That's right. And I think the rheumatologists are getting pretty wise to this now. They do take a look at the woman's age often before they come down hard and fast that this is fibromyalgia and not something else.
So, women presenting in their mid 40s to primary care with sleep disturbance and anxiety, this may be something they've never experienced before, as in Angie's case, and they're often prescribed SSRIs. So, I wonder if you can just comment on whether or not this is appropriate management.
Yeah, I think that's a good question because it became almost second nature to use SSRIs to manage menopausal symptoms generally, particularly around the time 20 odd years ago when there was concern about HRT safety. So I think that, the mood symptoms are common. They crop up early and they can be really severe in a good, 25% of women. And as you've mentioned, occurring in women that have never had any pre-existing mental health issue. In saying that, for those women that have a past history of depression or anxiety, menopause can be a high risk time for them, particularly if those mood issues have been hormone linked. So the women that we see with a history of premenstrual syndrome, PMDD, postnatal depression, we are more likely to see them running into issues at menopause. And the sleep deprivation that comes with menopause obviously makes a lot of that worse. So it becomes a really key issue to sort out. So I think for all of these reasons, it's become very clear from the research that menopause hormone therapy is more effective than using an SSRI to deal with these symptoms. And we have gone way past, the day of feeling concerned generally about hormone treatment safety. So it really should be the first line of management in this area rather than an SSRI.
Wonderful. Thank you for clarifying that. So we talk more to Angie and we complete the Australasian Menopause Society symptom score sheet. We conclude it's likely that she's perimenopausal. She scored 16 on this sheet. So what are the indications for MHT for Angie, for a woman in the perimenopause?
I think that the symptom score sheet that you're referring to is the green climacteric scale, which I think is a really useful way to gauge the severity of symptoms. And she scored 16, so that tells us, because that score is higher than 15, that her symptoms are likely to be linked to menopause. And, in the symptomatic women that we see, the scores can sit anywhere between 20 and 50 quite commonly. So, that gives you a bit of an idea that for some women in the perimenopause, these symptoms can be having quite a significant impact on their quality of life. So I think, the indications for MHT in the perimenopause are really when women start to notice a significant impact. It becomes a judgment call on their part that, these symptoms are having an impact such that they really do need something to manage those. So I think it's a personal call to some extent. I would say that starting MHT very early in the perimenopause can be challenging because it adds obviously an extra layer of hormone to what is a roller coaster of hormone changes in the background. And yes, it will take away those very low levels of hormones, but it doesn't stop that great variability. So I think if you do go ahead and start MHT in this context, then warning women that things are going to change from time to time and that you may need to change the dose over time really sets them up for a more successful experience.
Just thinking about the combined oral contraceptive pill as a form of MHT, is this an option?
Yeah, it is. It's not a foolproof option. Somewhat surprisingly, it's not as effective as MHT, but I think if a woman doesn't have contraindications to its use, then if she requires contraception, period regulation, and some degree of symptom management, then, I think it's not a bad thing to consider.
And if we were using this as an option, Anna, would we be using it as a continuous regime or should we be giving her a bleed each month?
Yeah, that's a really good question. I think it should be used continuously. And I guess, a lot of us over recent years have moved to more continuous use of the combined pill anyway, and we know that that's quite safe to do that. But, having her cycling every month and having a week off when the symptoms are likely to come back and be at their worst is certainly not helpful. So, yeah, continuous, definitely.
So Angie comes back to us after pondering her initial consultation, and she's keen to try MHT. She says she's not keen for a Mirena at this stage, and she asks you, what is the safest regime?
And I think that's a question we all get, isn't it? Everyone wants, the safest possible option. I think, fortunately, the estrogens that we do have funded in New Zealand are all body identical. So that's a good start. And I think in a young, fit, healthy woman at menopause, her choice of whether she goes down the path of oral estrogen or transdermal therapy is largely a personal one. There are clearly advantages in using transdermal estrogen in women that are older. So anyone over 60, we would greatly prefer that they were on transdermal therapy. And in the younger group, if they have inherent risk factors for clotting, so that might include the group who are overweight or obese, who have migraines, hypertension, diabetes, then we're going to prefer the use of transdermal estrogen for that group. And then as far as the progestogen goes, now that we have micronized progesterone available, I think that's become our go-to first-line option because it is clearly the most neutral of all of the progestogens that we have access to. It doesn't attenuate any of the benefits that estrogen has on our cardiovascular risk profile. And clearly from a breast safety perspective, it's a much better option in that regard. I think its only downside is that it's less effective at bleeding control. So for some women, that can be an issue. So generally our choices would be eutrogestin plus estrogen given in an appropriate way for the woman and the choice she wants to make.
Angie asks you about contraception. So does she still need contraception when she's using a transdermal patch and micronized progesterone? And what would you suggest?
Yes, she still needs contraception because menopause hormone therapy does not provide contraceptive cover. So I think, we do have a range of options to consider there from, barrier methods of contraception, the progesterone-only contraceptive, the Mirena, IUS, the normal copper IUCDs. So there's a range of options we can discuss with her.
And I've got some specific questions about progesterone. So firstly, when we give northisterone as part of MHT, it's a high dose, higher than the progesterone-only pill. Can this be used as contraception?
Well, it's marketed in low dose, as we all know, as Noriday for contraception. So that dose is 0.35 milligrams daily. Generally, when we're using it as part of an MHT regime, the dose we're going to need to use for endometrial protection will be anywhere from 0.5 to 1 milligram a day, depending on the dose of estrogen you're pairing with it. Interestingly, there's actually no data on contraceptive cover on that dose. And in fact, if you look at the manufacturer's product information sheet, it actually states that if you're using it in those doses, an additional contraception is required. So I think, being mindful of that is important. As far as Cerazette or desogestrel goes, there is limited, but some data suggesting that if you double the dose to 150 micrograms, that will provide some endometrial protection. But that data is very scanty. And I think for that reason, if I go down that path, which I do rarely, but sometimes, I do monitor the endometrium, and I would do that preferably by annual scans of the endometrium. I do the same thing if I'm using eutrogestin vaginally, and that is kind of a novel way of administering the eutrogestin for women who are getting side effects related to progesterone therapy. So if it's pushed high into the vagina, it gets well absorbed directly into the uterus, and that sees the bulk of the absorption, and you reduce and minimize as much as you can the systemic absorption and therefore hopefully the side effects they're getting. But there's minimal data there in terms of endometrial safety and guidance in terms of what doses and frequency need to be used. So again, in the very few women that I take down that path, I would be very cognizant of keeping an eye on their endometrium.
Wonderful. Thank you for clarifying that. So between Angie and yourself, you agree to start MHT and you decide on a transdermal estrogen, micronized progesterone, and a progesterone-only pill for contraception. What would be your typical starting dose, and when would you review Angie?
Yeah, I'm very much of the start low, go slow school of starting hormone therapy. So I would tend to start with a lowish dose of estrogen. So if she's going transdermal, that would be with 25 micrograms of patch estrogen. If she'd chosen to go orally, probably 1 milligram. And then because she's still having periods, we would use the Utrogestin cyclically. And classically, that's used in a dose of 200 milligrams a day for a minimum of 12 days a month. And then obviously combine that with the POP of her choice. We then recognize that it can take, 6 to 8 weeks for the full effect of starting estrogen to be seen. So you'd want to give her at least 4 to 6 weeks on treatment before you reviewed her response to that and then made appropriate dose adjustments.
And you've mentioned 12 days of Utrogestin. At what day do you start that?
I think for ease of remembering, we just tend to drop it in for the first 12 days of the calendar month. If you're trying to kind of work it in with a cycle, it can get very messy and women can get very confused. So I think if it's just started at the beginning of each calendar month, A, they can remember, and B, usually eventually you'll start to see their own cycles coming into a regular, predictable pattern with that.
Wonderful. Thank you for that. So Angie comes back for her 8-week review. She's sleeping better. Her anxiety is improved. She has no intermenstrual bleeding. Her withdrawal bleeds are light and lasts for 5 days. She is brighter in her mood. We repeat her symptom score, which is now dropped to 10. She is more energized and is exercising regularly. Angie asks, does she need to increase her MHT to get complete resolution of her symptoms?
I think it's important to preface any initiation of MHT with expectations. And, symptoms don't always completely disappear on therapy, but you certainly want to get them down to a very manageable level so that you return her quality of life as close as possible to normal. So I think any adjustment in the dose would really depend on how severe any residual symptoms were. If she was still waking most nights, if she was still feeling a bit hot and bothered, if mood wasn't completely, back to normal, then you may make some subtle adjustments and reassess things, and again, in another 6 to 8 weeks.
So using that score sheet, do we expect a specific drop? Are we looking for a number there, or it's really just symptom resolution and acceptability of those symptoms?
I tend to go largely on how a woman is feeling, but the green scale is quite useful because if the score drops to 10 or less, that's pretty much what you expect on effective therapy. So it's unlikely to get to complete zero, but I think if you see it dropping, at least you know you're heading in the right direction.
Wonderful. Angie's next question is around the need for transvaginal estrogen. Does she need this, and what are the indications?
Yeah, the indications there are very, very much the classic symptoms of genitourinary dysfunction, and they can be broad. It can be the vaginal dryness that creeps up on pretty much everyone over time, the dyspareunia, which is partly related to vaginal dryness. It's partly related to the shrinkage in the length and the diameter of the vagina with time, but it may also be the bladder symptoms, so the recurrent UTIs the women can experience, or urethritis that often gets confused with a UTI, but you do a urine specimen, there are no bugs, but, a few white cells. And so women can get, a whole host of genitourinary symptoms that, can respond really nicely to vaginal estrogen. And this will become a lot more common once they get sort of 4 or 5 years out from menopause proper.
So how can we tell if Angie is menopausal when she's on cyclical MHT?
Yeah, well, that's a good question because it's pretty challenging, obviously. If she's having regular induced periods because of her cyclical progestogen therapy, then you haven't got that period cue. Neither do you really have any cue from measuring hormones because, LH, FSH, estrogen levels are not going to be helpful. If you measure her AMH, which is a marker of ovarian reserve, that's going to have reached 3 to 5 years before menopause, so that may not be helpful. So often we just have to take a punt and say, well, you've been on cyclical therapy for a wee while. Why don't we just switch it to continuous and see how you go? If she starts to bleed erratically, then you may need to take her back to cyclical therapy and then try again a little while later. But it is just, taking a punt often.
And can you just clarify, you said when she's been on it for a while, so are we talking about a year, 2 years, or closer to 50?
Yeah, I think I would usually go for about a year as my first try. And then if she does bleed and we have to return to cyclical therapy, I'd say to her, well, maybe give it another try in a further 6 to 12 months.
Wonderful. Great. Thank you for that. So we decide to transition Angie to a continuous regime. What do we need to do with her dose of micronose progesterone?
That's a really good question, because I think that very much depends on what dose of estrogen she's ended up on. And there's been some controversy about how exactly we should go about this. But at the moment, the best evidence would suggest that if she's on 50 micrograms of transdermal estrogen or less, then transitioning her to 100 milligrams every day of micronized progesterone is the way to go. If she's required doses of estrogen that are higher than 50 micrograms, so 75 micrograms plus, then you would need to have her on 200 milligrams of eutrogestin every day.
And at what point can we discontinue the progesterone-only pill for contraception?
Yeah, there's been some work in this area, and I think there is quite a lot of clarification, which is useful. So if she has reached menopause at 50 or older, we would continue some form of contraceptive cover for a year. If she reaches menopause before 50, then the advice is that the contraceptive cover is continued for at least 2 years.
Wonderful. Great. Thank you for clarifying that. Thank you, Anna, for your insights today in discussing Angie's perimenopausal management. To conclude our podcast, your take-home messages.
Yeah, I think I'd have probably 5 points. The first would be that we need to recognise that symptoms of menopause can precede the onset of period changes. Secondly, that mood changes can occur early and they can be significant in a good 25% of women. Thirdly, that menopausal symptoms can be subtle. They can be misinterpreted as being linked to other non-hormone related conditions, and classically that would be cardiological or rheumatological problems. Fourthly, that the combined contraceptive pill can be an effective option for women who require both contraception and some degree of symptom management. And then lastly, I think just being aware that the standard progestogen doses used in the progesterone-only pill don't confer endometrial protection when they're used with estrogen. And even with desogestrel, there is still fairly scanty information regarding the appropriateness of doubling that dose.
Wonderful, Anna. Thank you so much for your time today. If you're a New Zealand GP and would like to claim CPD points for listening to our podcasts are eligible, so please log them. You'll also find a list of resources used in making this podcast on our website, goodfellowunit.org. Thank you for joining us today.